Hi, this presentation is on drugs used for treatment of peptic ulcer and gastroesophageal reflux disease. Peptic ulcer. Acid peptic disease is very common. Peptic ulcer is mainly caused by imbalance between aggressive factors and defensive factors. Aggressive factors are acid, pepsin, bile, and H. pylori infection. Defensive factors are gastric mucus, bicarbonate secretion, prostaglandins, NO or nitric oxide, high mucosal blood flow, and intrinsic resistance of mucosal cells. So if there is a increase in aggressive factors, then peptic ulcer may happen, and if there is a decrease in defensive factors, then also there are chances of peptic ulcer. There are two types of peptic ulcer: gastric ulcer and duodenal ulcer. Gastric ulcer, which happens in the area of stomach, that's why it is called gastric ulcer. Duodenal ulcer happens in duodenum, that's why it is called duodenal ulcer. Mechanism of peptic ulcer: there is increase in hydrochloric acid secretion by parietal cell in stomach, and which is most common factor or cause of peptic ulcer. Hydrochloric acid secretion by parietal cell can be stimulated by histamine, acetylcholine, or gastrin. Now, role of acetylcholine: food intake stimulates vagus nerve, which releases acetylcholine, which act on muscarinic receptors in parietal cell, and which leads to stimulation of proton pump. And stimulation of proton pump leads to increase in acid secretion. Proton pump is also called hydrogen potassium ATPase. So it is an enzyme. Anything which stimulates proton pump will increase hydrochloric acid secretion in stomach. Role of histamine: acetylcholine also acts on muscarinic receptors on enterochromaffin cells or ECL cells, which leads to release of histamine from ECL cells. And this histamine acts on H2 receptors on parietal cell, and which leads to stimulation of proton pump, and stimulation of proton pump leads to hydrochloric acid secretion. Now these enterochromaffil cells are also stimulated by gastrin which act on gastrin receptors on ECL cell or enterochromaffil cell and leads to secretion of histamine. So that histamine will act on H2 receptor and will stimulate proton pump and increase hydrochloric acid secretion. So histamine secretion can happen by acetylcholine as well as gastrin both. Role of gastrin: food intake also stimulates gastrin releasing peptide or GRP, which stimulates gastrin cells to release gastrin. So GRP act on gastrin cell, which will secrete gastrin. Now gastrin will stimulate proton pump, and proton pump stimulation will lead to increase in acid secretion. So gastrin also acts on ECL or enterochromaffil cell, which will lead to secretion on secretion of histamine. So histamine will again act on parietal cell, and which will stimulate proton pump in parietal cells, and stimulation of proton pump will lead to secretion of acid. Classification of anti-ulcer drugs: first class is H2 antagonists. Examples are cimetidine, ranitidine, famotidine, roxatidine, and nizatidine. Next class is proton pump inhibitors. They block the proton pump, which is final step in the secretion of hydrochloric acid. Examples are omeprazole, esomeprazole, lansoprazole, pantoprazole, rabeprazole, dexarabeprazole. Next class is anticholinergic drugs. These drugs they block muscarinic receptors and prevent the action of acetylcholine on muscarinic receptors. If muscarinic receptors are not stimulated, then the proton pump on parietal cell will not be stimulated, and that will lead to decrease in acid secretion. Next class is gastrin inhibitors, which inhibit the gastrin release. If there is no gastrin release, then gastrin will not act on parietal cell, and it will not release histamine from ECL cell, and that will also lead to the decrease in acid secretion. Example is proglumide, which is competitive antagonist at gastrin receptors and prevent the action of gastrin. Next class is prostaglandin analogs. Examples misoprostol, N-prostadil, arbeprostadil, and rioprostadil. Next class is acid neutralizers. They chemically neutralize the hydrochloric acid. Examples sodium bicarbonate, sodium citrate, magnesium hydroxide, magnesium triasilicate, aluminum hydroxide, megliterate, and calcium carbonate. Next class is ulcer protectives. They protect ulcer physically. They provide coating on the ulcer. Examples are sucralfate, colloidal bismuth subcitrate. Next class is anti-H. pylori drugs. So there is a data which suggests that there is a role of H. pylori in peptic ulcer. If there is a H. pylori infection, then ulcer healing takes time. So that's why eradication of H. pylori is required. So along with the acid secretion inhibitor, antibiotics are also used to eradicate H. pylori. And antibiotics which are used for eradication of H. pylori are amoxicillin, clarithromycin, metronidazole, tindazole, and tetracycline. Coming to S2 blockers, they block histamine S2 receptors in parietal cells and inhibit action of histamine, thereby inhibiting acid secretion. They decrease both volume and acidity of basal, basic acid secretion, nocturnal, nighttime acid secretion, and food-induced secretion. There is a dose-dependent inhibition of acid secretion. The higher the dose, more is the inhibition of acid secretion. Gastrin-induced acid secretion is also reduced. They rapidly and well absorbed orally, but they undergo first pass metabolism by liver and excreted in the urine. Antacids reduce their absorption, and there are many drug interactions, more with cimetidine. Uses of S2 blockers, duodenal ulcer, gastric ulcer, stress ulcer, gastritis, Geringer-Olaisen syndrome, GERD, prophylaxis of aspiration pneumonia, and for treatment of urticaria in combination therapy. JD syndrome is Geringer-Olaisen syndrome, in which there is excessive acid secretion. GERD is gastroesophageal reflux disease. Aspiration pneumonia happens when there is a aspiration of hydrochloric acid in the lungs. When in case of acidity, there is excessive acid secretion which may come to the mouth, and if the patient during surgery is unconscious, then acid content may go to the lung. That will cause aspiration pneumonia. So these drugs are used to decrease acid secretion. If there is a less acid secretion in the gastric content, there are less chances of acid going to the lungs. Urticaria is a skin disease in which there is itching, etc. And mainly H1 receptor blockers are used, but in resistant urticaria, they may not work. And in those cases, S2 blocker and S1 receptor blocker both are used in combination. S2 blockers are available as tablet as well as injection. Now coming to proton pump inhibitors, they inhibit proton pump, the final step in acid secretion. They irreversibly inhibit proton pump. That means new proton pump synthesis is required for acid secretion, which will take 16 to 18 hours. That's why they are longer acting and very effective acid secretion inhibitors. Proton pump inhibitors are inactivated by gastric acid. Therefore, they are available in the enteric coated formulation, which are given on empty stomach. Because of enteric coating, the drug is not released in the stomach and acid cannot destroy it. These agents from enteric coated formulation, they are released in the intestine from where they are absorbed. Food decreases their bioavailability. Decrease in acid secretion also leads to reduction in absorption of many drugs. There is high protein binding, they are metabolized in the liver, and they inhibit hepatic microsomal enzyme. That means there may be interaction with other drugs. Uses: duodenal ulcer, gastric ulcer, stress ulcers, gastritis, GERD syndromes, gastroesophageal reflux disease, prophylaxis of aspiration pneumonia, available orally as well as injection. On long-term use, there are reports of causing osteoporosis because of decrease in calcium absorption if these drugs are used for longer time. Coming to anticholinergic drugs, they block action of acetylcholine on muscarinic receptors. If there is blockage of muscarinic receptor, then in the parietal cell, the proton pump will not be stimulated and there will be decrease in acid secretion. They also block muscarinic receptor on ECL cell or intrachromophil cell, and because of that, there is a less secretion of histamine. There is also decrease in volume of gastric juice. They are not very commonly used because many anticholinergic adverse effects are there, like dry mouth and blurring of vision. Coming to prostaglandin analogs, they are cytoprotective. They increase mucus and bicarbonate secretion. They decrease acid and gastrin secretion, and they also increase mucosal blood flow. They are not commonly used drugs. They are not very commonly used drugs because of poor patient acceptability and many adverse effects like diarrhea, abdominal cramps, and uterine bleeding, and many other side effects. Next class is acid neutralizers. They neutralize gastric acid in stomach chemically, and pepsin activity is also reduced. You can see the example in this reaction: sodium bicarbonate react with hydrochloric acid, which form sodium chloride, water, and carbon dioxide. Usually, antacid combinations are used. There are antacids which are systemically absorbed. Also, they are called systemic antacids like sodium bicarbonate and sodium citrate. Others are locally, they are not absorbed from the GI tract. They neutralize the acid locally in the stomach. Sodium bicarbonate may increase the sodium level. This precaution has to be taken in hypertensive patients. Next class is ulcer protectives. These agents, they form sticky gel which adhere to the ulcer base and which act as a physical barrier. Colloidal bismuth subcitrate in this class may increase mucosal prostaglandins, mucus and bicarbonate protection also. It may also decrease H. pylori. So it has multiple mode of actions. Antacid reduce its efficacy and it absorbs many drugs. There are multiple time dosing, that's why not commonly used. Rabamipide is next drug in this class, which is a new drug which acts by increasing expression of epidermal growth factor and epidermal growth factor receptor. So this epidermal growth factor causes epithelialization of the tissue in ulcer and help in promoting healing of the ulcer. Now coming to anti-H. pylori drugs. H. pylori is a gram-negative bacillus which attaches to gastric mucosa and persists for life after infection. And 90% of the patients with gastric ulcer and duodenal ulcer, they have been tested positive for H. pylori. So H. pylori eradication is associated with the faster ulcer healing. There is a data which shows that if you eradicate H. pylori, there will be faster healing of ulcer. And usually combination of antibiotic is required for H. pylori eradication. Because if single antibiotic is used, that may not work and the H. pylori will become resistant. That's why combination of antibiotics are used. Acid suppression by proton pump inhibitors and S2 blockers increases antibiotic efficacy. That's why antibiotics and proton pump inhibitors usually they are used in combination. There are many 1 and 2 weeks treatment combinations available. Below given example, you can see example of omeprazole 20 mg plus amoxicillin 1000 mg plus clarithromycin 500 mg given twice daily for 1 week. Coming to gastroesophageal reflux disease or GERD. In this, there is a decrease in lower esophageal sphincter tone, the wall or sphincter between the esophagus and stomach. Tone of that wall become loose, and because of that, the gastric content along with acid may reflux back to esophagus, which may cause erosion and ulcer and pain, and there will be pain on swallowing, and there will be difficulty in swallowing, which is called dysphagia, and there is also risk factor for carcinoma if that happens. Now, drugs used in treatment of GERD. Proton pump inhibitors are the main choice or drug of choice. Then H2 blockers are used. Then antacids are used for relief of heartburn. And sodium alginate, which forms sticky, frothy layer which floats on gastric content. And then prokinetics agents, which increase the gastric motility. Examples are metoclopramide and cisapride. And these drugs help in facilitating gastric emptying. That's all in this presentation. Thank you very much.